Hello and welcome to today's Tiger webinar. I'm Lydia Palmer from RIT's Division of Development and Alumni Relations, and I'm your moderator for today's webinar. We're happy to have you join us today, and we hope that you and our entire Tiger family are well and weathering this global challenge. We want you to know that the RIT Office of Alumni Relations is available to help all Tigers in the coming weeks with a variety of needs, including new virtual content, learning opportunities, and networking and career assistance in the coming months as our workplaces and our world work through the post-pandemic realities. We especially encourage everyone to connect to the RIT Alumni Association social media channels, including Facebook, LinkedIn, and Twitter, where you will find up-to-date communications and opportunities to connect with other Tiger alumni in your region and your industry. Those links are found in the chat box, and the chat box can be opened by clicking on the chat tab at the right of your webinar window. Many in our RIT family have asked how they can help our students and the university during this crisis, and we are incredibly grateful for those offers. We especially want to thank those who supported RIT during this week's Global Day of Giving. There is currently an unprecedented need for financial aid scholarships for our current and incoming Tiger students as we move into the new academic year. If you are able, please make a gift at the link in the chat box, and we truly thank you. We want to ensure that everyone is ready and familiar with the presentation tools. If you are joining from a remote location and are currently signed into your company's VPN, we encourage you to close that channel during the webinar to increase the quality of transmission. The webinar platform is secure and does not require VPN access. All attendees have joined in mute mode. However, your questions can be entered in the chat box at any time throughout the discussion. We will make every effort to address all your comments and questions throughout the webinar. You are joining the event using broadcast audio. If you wish to dial in by phone, dial-in information is provided in the chat box. Live captioning is also being provided, and you can find the link to access that in the chat box as well. Today's webinar will be recorded and made available, complete with captions, in approximately 1 week following today's event. All participants will receive an email with the link to the recording. If you have any technical questions, please feel free to type those into the chat box as well, and we will do our best to get you the appropriate answers. And now on to our webinar. We are extremely happy to welcome 4 RIT alumni who are serving their communities at the front lines of the COVID-19 crisis. Melody Colmetz is a 1995 alumna from RIT's Physician Assistant Program and currently an assistant professor there, as well as an instructor for Monroe Community College's EMT course. She is also a paramedic at Gates Ambulance. Amelia Rosedale received her BSMS in 2018 from RIT's Physician Assistant Program and is currently a PA in emergency medicine at Rochester Regional Health Unity Hospital in Rochester. Nicole Bingo received her BSMS in 2018 from the RIT PA program and currently works in Manhattan at the Mount Sinai West and Mount Sinai Morningside emergency departments. She works in the pediatric ED, adult acute AD, and fast track evaluation units, and has been trained and certified in sexual assault forensic examining. And finally, Eric Thomas received his BSMS from RIT's PA program in 2016. He is currently assigned to the Departments of Cardiac Surgery and Emergency Medicine at the University of Rochester Medical Center. To all of you, we are incredibly grateful for your dedication to our communities and to our health. Our audience is all yours.
Thank you so much. I'm scrolling through the list of people that have joined us tonight, and I'm happy to see some familiar names and familiar faces. So thank you all for spending some time with us on a Friday evening. I was very honored to be asked to participate in the webinar. Since this pandemic began, I really felt that there was a great need for more education to the general public about what is going on and about how they can protect themselves. So I thought we would perhaps begin the webinar by each of us talking a little bit about what our role is in healthcare, or was prior to the pandemic, and how it's changed since we have kind of pivoted as PAs during this pandemic situation. So as you were kind enough to mention, I teach full-time in the PA program. I was lucky enough to be a graduate of the first year of the PA program. Although clinical practice has been a really important thing for me. So I work clinically 1 day a week at Rochester Regional in mobile wound care. So I go in and out of several of the assisted living, adult daycare, and skilled nursing facilities. And I also was involved in EMS prior to becoming a PA, and I've maintained that EMS certification. So I also work approximately a shift a week at Gates Ambulance as a paramedic. So that's kind of what my life was like before the pandemic. After the pandemic hit, sadly, one of the first cases in our area was in one of the nursing homes that I serve. So that nursing home shut down, has been shut down to the public and to non-essential staff since then. So my work in wound care or mobile surgical services has transitioned to telemedicine. So that's been an exciting thing to learn. I did feel like it was a really good opportunity to stay up and educated about this new disease that we're dealing with. So the opportunity existed to continue working on the ambulance. So I appreciate the opportunity to continue taking care of folks in their homes and in their workplaces, helping their loved ones when they are really, really frightened. I'm sure some of you that work in the hospital setting can speak to what they're seeing on that side, but it's very difficult for patients to have to go to the hospital alone without their typical support systems. So I feel like I've been trying to kind of make some changes in that regard in the pre-hospital setting in terms of what we advise people to bring with them to the hospital, talking about advanced directives and kind of educating some of my other fellow EMS providers in that regard. So when I work as a paramedic, oftentimes I bring patients to Amelia and transfer them to her in the emergency room. So I thank her for taking some time out and joining us tonight. So I'll let her tell you a little bit more about what her role was before and what she's transitioned to now.
Okay, great. So I work full-time as a physician assistant in the emergency department at Unity Hospital, which is in Greece, New York. So still, suburban, but we see a lot of, the urban population and a lot of rural population. So it's pretty diverse. We see mainly adults and actually mainly elderly patients. We're a geriatric accredited emergency department. But we do see some kids here and there. So I work there full time. I'm also per diem at the medical observation unit at RGH, and I just finished my sexual assault forensic examiner training. So I'll be doing that out of Unity. Since the pandemic started, I was still full time in the Unity ED. I was here and there at RGH per diem in the medical observation unit, but per diem shifts kind of have been dialed back due to, lower volumes of patients. So I'm not doing per diem as much anymore. So I'm in the ED, but our PAs and nurse practitioners in the emergency department, 2 of our 12-hour shifts a day have been transitioned into the COVID-19 testing tent, which is set up outside of Unity. So I had to be trained in taking care of patients in the tent, which is completely different. Part of my contract through Unity is we do staff the walk-in care center at St. Mary's a couple times a month. So I'm used to urgent care, but this is like quick, very quick urgent care. So patients will drive up in their car, they'll show their license and their insurance card in the windshield, and then they move forward to another tent where, myself or another, physician assistant or nurse practitioner screens them. What symptoms are you having? We have a technician take their vital signs. If they have a fever or, an elevated heart rate or their oxygen is low, sometimes they'll be sent immediately into the emergency department. So there's been patients that have come through who, a normal pulse oximeter reading for oxygen is, we like it above 90%. So there's been patients who we've found who have, 60% readings in that tent, and then they just get escorted promptly into the emergency department. If you're stable and we think you qualify for testing, so there's a pretty, strict algorithm for testing that we follow. There's some leeway if you document appropriately, but we group people, are you a candidate for a test? Are you not? If you are a candidate, you get sent back to tent 3, which has, 2 other providers, either a physician assistant or a nurse practitioner there. And then they are the ones that do the nasopharyngeal swab and then send it out for COVID testing. But there are people that we do have to send away still. I mean, testing has come a long way in this area, but there are people that we have to turn away. I mean, multiple people a day. The people that do get sent to the third tent, we can also do a rapid strep test there. So sometimes if they have a sore throat, and they have a cough, we'll do both tests. And then we're able to tell them if they have strep throat, send a throat culture too if the rapid strep test is negative. And we're also able to do nebulizer treatments in people's cars. So we can have them pull forward to some oxygen tanks and they hook the nebulizer treatment up, if they're wheezing or they're asthmatic. Then we have a nurse that's responsible for contacting every person that has had a swab done, whether their result is negative or positive. So in medicine, routinely, the saying goes, no news is good news, but here we'll tell you if it's positive or negative. We provide people with work documentation for work. We have discharge instructions pre-printed out for them. So that's a lot of what I've been transitioning into. I still obviously am in the emergency department doing my, traditional scope of practice, but I'm also in the tents too.
So it's a good opportunity to sort of compare and contrast. You told us a little bit about what is going on in the emergency rooms here in Rochester. Nicole, you're in a totally different environment. So maybe you can kind of jump off of what Amelia said and compare and contrast what it's like for you. So tell us a little bit about what you were doing in your role prior to this pandemic and how has that changed for you?
Yeah, of course. So we have a bunch of tents as well. I work in 2 emergency departments and I've been pretty lucky. I haven't been displaced too much. I've only been in the tent once. We have a lot of off-service PAs who have been incredible and super flexible, from neurosurgery to ortho PAs to OB/GYN PAs, who are the ones that end up staffing the tents. So they're the ones that have been totally trained in how to handle the tent, how to basically treat and treat. They're in and they're out. And if they need an aerosolized treatment, they can get it in the tent. If they need a chest x-ray, we had a portable chest x-ray out there too, which was pretty cool. Lots of telehealth. So the attending would actually still be in the emergency department. And when that PA was ready to either discharge or if they thought they needed a little bit more, we were able to communicate through that. So we weren't having to have any unnecessary exposure, which is pretty cool. And based off of that, if they were sickly or if they just weren't cutting it out in the tent, they got sent back into the emergency departments where we would pick them up and then further carry on their care. So I've still been in the acute side, the resuscitation side, the eval side, which is kind of like an urgent care where it's still pretty quick. And then for safe, it's definitely gotten cut down because I've taken lots of per diem shifts. So I've had to cut back on that. But typically I'm on call for that about 3 to 4 times a month for 12 hours a day. So this whole month I haven't been able to be on call, but hopefully next month when things slowly start to normalize a bit, I'll be able to pick that up again, which is exciting to have some change of pace.
Since you're sort of in the epicenter of one of the biggest areas in New York kind of hit with the virus, can you tell us a little bit about what patient volumes have been like for you down there?
Yeah, so starting January, normal, end of February, it started to really pick up where it was a pretty bad flu season. And then obviously COVID started to be introduced, and end of February, early March, it was still very just trickling in. So we'd get the COVID rule outs. I traveled here, I was on an airplane, I connected in some part of China, not even near Wuhan. So it was trying to figure out what to do with these people who are otherwise young and healthy and are statting fine, but are a public health risk potentially. So that was interesting how to deal with that. And then early April, we peaked April 9th, and then it's just been pretty heavy in April. All the other emergencies, so MI, strokes, things like that, have really decreased. So whether or not these people are just happening to them at home, or a lot of the things that we see are rule outs and then we admit for further imaging testing, what be it. But we were probably down about 50% end of April, but our admission rates were up 30%. So we weren't seeing that many people, but the people we were seeing were critical. So it felt like a marathon each shift, how each patient you saw required so much of your time and energy. And then in between that, you had all of the resuscitations of the people who are coming in from nursing homes or who otherwise are young-ish and healthy, who are still sitting in the 50s, 60s, who need immediate care right then. So it's been pretty crazy, but slowly starting to normalize, where I'm excited to do other things than respiratory care, where I'm doing abdominal stuff, I'm doing OBGYN stuff, I'm suturing, I'm doing ortho things. So slowly but surely we're getting back to it, which is exciting.
Excellent. Thanks so much for speaking about that. Eric, you work more on the inpatient side of things. So we've heard a little bit about pre-hospital care. You have a unique perspective because you kind of do both, but can you tell us a little bit about once the patient gets admitted, tell us more about what your role was before the pandemic began and how it's changed. And maybe you can speak a little bit about how the hospital system has kind of changed structure in order to accommodate for admission of these COVID patients.
Yeah, so I typically work in a cardiac ICU environment. So we're typically taking care of patients who have had heart transplants or have had bypass surgery or have had valve replacements or require some sort of mechanical support for heart failure, whether it's a temporary or permanent device. And so I work at a hospital that does transplants of heart, liver, kidney. And kind of, I guess, what's important, an important note, when this all started, we were doing none of that. And we've kind of started to resume some of that as of now. The timing, of this webinar is good. But I think I have a very different view now, kind of 8 weeks into things, than I would have if this was March 5th or March 1st. So from our standpoint, and in my experience, what our system did is we created something called a HIDU, which is a highly infectious disease unit, if you will. And what that entailed was creating, we had a mandate from the state to increase hospital capacity by 50%. We have about 900 beds in our hospital. So it was no small task. And a large percentage of those beds had to be critical care accessible beds because of what was going on in New York City. So of the 6 adult ICUs at Strong, a lot of them were converted to HIDU units. So at one time, probably April 15th, I think was the peak, there were COVID positive patients occupying 4 of those 6 ICUs. And so if you think operationally about the challenges involved with that, many of the ICUs that live in a normal space had to be uplifted to other areas. And so, for example, our surgical ICU actually moved down to the post-anesthesia care unit. Where I typically work in the cardiac ICU, we moved into a medical intensive care unit. The burn and trauma ICU moved in and occupied space with us, and also occupied space in another ICU. And so the reason that a lot of that was done was to increase capacity and also create safer space for clinicians and nurses to work, because a lot of those beds that were uplifted were negative pressure beds. So it was more safe for staff to do procedures and intubate patients, put a breathing tube in patients in those environments than it is in non-negative pressure environments. Kind of operationally inside the hospital, a lot of the staff from the other ICUs, the census or the number of patients that were admitted to those units dwindled significantly. And so a lot of us were reassigned to work either our entire schedule or a portion of our schedule in the HIDU, in the COVID positive ICU environment. And that presented, a unique set of challenges. You have a lot of subspecialists, cardiac ICU people, surgical ICU people, burn trauma ICU people, neurologic ICU people, all trying to work together of course, for one mission, but it was a unique environment because everyone has their subspecialty area that they're most comfortable working in. And so that was all. I look at that as a challenge, but also a really kind of cool thing that came out of this is we had a lot of teams working together that don't traditionally work together. So that has been very cool for us. You know, you're working with people that you don't usually work with, taking care of a unique situation with, of course, the big mission in mind. So that's kind of been, and where we are now from a Rochester standpoint is we're certainly on the decline. And we're on the incline with, I don't want to say normal patients, but elective surgeries and things like that starting to ramp up again. And so it's been very unique. My hospital is a hospital that usually operates at an average of 108% capacity. And at one point at the lowest, we were down to 48%. And so, of course, with that comes a lot of the financial challenges, which we're now seeing staff furloughs and kind of the backlash of some of that. So that's kind of been operationally and you know kind of clinically where my head has been from an in-hospital environment.
Great. Thank you so much. I do see some good questions there in the question side of things. So maybe it's a good time to transition over there, answer a few of those questions, and then I have a
Yes.
couple more questions for you.
Thanks, Melody. Yeah, I was just going to jump in here and let you know that you've got a lot of kudos from people. So John Oliphant mentioned each of you as 4 of RIT's finest graduates. So I think that's great. There was a question, and I do believe that it was answered, which is that the PA program right now is a 5-year BSMS, correct?
Correct.
Correct. And there was a question regarding people who are experiencing symptoms. If they are too tired or weak to drive to a test site, they should still go to emergency. Is that correct?
So I'm very appreciative of the fact that someone actually asked that question, because that was one of the really important take-home messages that I wanted to emphasize. In my 30 years as an EMS provider, since this pandemic began, I have taken care of some of the sickest patients I have ever taken care of in their homes. Amelia mentioned it. I can think of one gentleman. His oxygen sat was 60%, and he was still chatting with me. He was joking with me that he couldn't see that I was smiling because I had a mask on. And I kept thinking, this must be a mistake. It must be a problem with the equipment. This can't be right. But when I thought about it, his wife emphasized the fact that he had been feeling poorly for about 5 days, and they had been back and forth with their primary care. And finally, he said, okay, I feel sick enough. I need to go. So the fact that his had been a steady, slow decline over the course of 5 days, he had been able to accommodate for that level of hypoxia, and that's still bad. So if people are feeling lousy, do not hesitate. Get to the hospital. Call 911 if you cannot get there. Your EMS services are more than happy to take care of you. They have the appropriate PPE to transport you, and that is the appropriate way to handle things. If you feel really badly, please, by all means, do not hesitate to call and get to the hospital. That being said, urgent cares and the tents are certainly great options for folks who aren't feeling sick enough to get to the hospital, but still feel like they need some care. So we hear lots of times, I didn't want to go because I was afraid of the virus and I thought I was going to get sicker if I went to the hospital. So please don't make yourself sicker by waiting.
So I'd like to comment on that real quick. So I supervise a staff of about 160 EMTs and paramedics at another private entity. But I'm looking at data on a screen that's behind my laptop. We pulled data about cardiac arrest. So basically, the sickest you can be in your home. And if you pull the data from our agency, we do about 15 to 20,000 EMS calls a year. And looking at our data, I pulled data back to 2017. And in April of each of those years, April of 17, April of 18, and April of 19, we traditionally average about 6 cardiac arrests per month. And this year, looking at 2020, that number has tripled. And so I think the alarming thing is that folks are staying home with symptoms for much longer than they should. And from our standpoint, I can't emphasize this enough. If you or someone you know is sick, the people are here to help you, and you will get excellent patient care at just about anywhere right now, and you will probably get the most efficient patient care that you have ever encountered. Um, and I think this is a big worry for us, is that a lot of patients are staying home for long periods of time with symptoms, and that's causing them to delay a presentation until it's inevitable. And then in some cases they're too critically ill um, to kind of survive. So the hospital, I say this, I feel completely safe going to the hospital right now. It's probably the cleanest it's ever been in a long time.
Yep.
And the same goes for all of your, outpatient clinics and facilities. They're constant cleaning. Everyone has a mask on. Everyone's washing their hands probably better than ever. So it is absolutely safe to seek any kind of care, and especially emergency care at this time.
Thank you
That's
for
terrific.
following up on that.
Oh, I'm sorry.
No, I was just saying thank you for following up my my anecdotal report with solid data.
Yes.
Yeah.
So we do have another question regarding testing. They ask if your hospital labs have experienced difficulty getting COVID testing supplies, and are they actually testing in-house?
Yeah, so
Anybody want to take that one?
I can answer on that. So in April, we really struggled with this, where there was points where we were admitting people who were very clearly COVID based on vital signs and clinical presentation and their chest X-ray, and we just did not have any swabs to test them. So we were admitting them and having to. I mean, at this point, the whole hospital was a COVID zone, so there were not any floors that were not COVID. The whole place was deemed like a COVID hotspot. So it didn't make that much difference when everything else pointed towards COVID, but we just got a big shipment. We're doing okay on that right now, and we also have rapid testing, so it comes back within like 30 minutes to an hour, and those are for people who are going to ICUs or who are going to the OR, who it's important if they're getting intubated for, like, they are coming in with appendicitis and things are going to be aerosolized, and it's important to know that. So it's pretty cool that we have that option now. We have only about like 10 a day, so they're on high restriction, but when we do need them, we're at the point where we pretty much have them now, which is nice.
There was a day where we were told that we only had 15 swabs left, which was in April, and that was really scary for like the whole hospital. Like, you have 15 swabs, so do with them what you will. And then we got some more in, so we switched over to different swabs. And Unity, it was about a week and a half, maybe 2 weeks ago, we started testing in-house, which has been awesome. So if we order a stat test, like Nicole said, for someone who we think is going to need to go to the ICU or be on, or be intubated and on a ventilator or be on CPAP or BiPAP, we prioritize their tests and put them in a stat. So we had results back in 4 hours, which was unheard of. And then everyone else, we were able to get results back in 12 hours, which is, reassuring to tell a patient that, doesn't qualify for admission. Oh, well, I'll call you later, or I'll have someone call you later and we'll tell you whether it's positive or negative. So, that was a huge, we were waiting at one point, like 4 to 6 days for results. And then it was like 2 days, give or take. And then to have it within 4 hours for the most critical patients was, it was amazing.
Yeah. At the beginning, I was taking our swabs. It could be like up to 10 days. We have a call center that was calling whether it was positive or negative. But it's just crazy how it could be from 10 days to now 30 minutes. It's pretty cool.
Now, that being said, I think we are really fortunate here in the Rochester area. I can tell you that both health systems communicate back and forth with each other on a daily basis, probably multiple times a day, and they're working back and forth together. So I think that that's a really important thing to emphasize, how lucky we are in this area that the systems work together to try to maximize testing availability for patients and to really put the patient first. Now, that being said, sure, we have the availability to do testing on patients that warrant it. There's still not enough testing available. So I feel obligated to say that because I don't want people running in the door saying, I want to be tested for COVID. They still need to be assessed appropriately, and a clinical decision needs to be made about whether a test is appropriate for them.
Yeah, we still aren't swabbing and testing people who are getting discharged. So they have to go to an urgent care, a city MD, but we unfortunately do not have that capability yet.
And Eric alluded to the fact that they're opening up surgical capabilities. So it's a requirement that anybody's going to have a procedure, have testing done prior to that procedure. So we want to make sure that there's enough testing available for those folks as well.
Terrific. Thank you so much. Now, we do have 2 other questions. I'm going to kind of tie them together because I think they all sort of work together. There's a question about how you assess whether a patient should go on a ventilator. How is it administered? And the second question was, are CPAP, BiPAP being used as a bridge to ventilation in COVID-positive patients, or less so due to fear of aerosolization?
Great question. Eric, do you want to take that one maybe first? And then maybe Nicole, you can speak to how things are going in your area.
Sure.
Yeah, so there was a lot of we didn't know a lot about COVID when we started. It's a brand new illness. It's not a brand new virus. It's a subset of SARS, which was an outbreak in 2002. Kind of came from the same genius, but different speciation, if you will, without getting into too much of the science. But long story short, we set a threshold at where I work. And so basically, if folks came in and they needed supplemental oxygen, I think you're probably familiar with the prongs that go in the nose called a nasal cannula. You can program those at different flow rates. So, for example, 2 liters a minute, 4 liters a minute, 6 liters a minute. We, where I work, set a threshold to 6 liters a minute. So if folks were requiring oxygen supplementation at 6 liters a minute or greater, we elected to put them on a ventilator. And the reason for that is there's a couple of reasons for that. Number one, as soon as you have someone on a ventilator, it's a closed system. So the risk of aerosolization or the risk of any of their secretions going out into the air and potentially contaminating staff goes down dramatically. Because it's a breathing tube, and then the breathing tube goes into the breathing machine, the ventilator, and it's all closed. Another reason for that is if you put someone, it's a dangerous procedure to put someone on a ventilator. Not a dangerous, that's the wrong word, high risk. So we determined that threshold was at 6 liters because it was safer to put someone on a breathing machine in a controlled environment before they were requiring 20, 30, or 40 liters of oxygen, for example. And then thirdly, the patients who were requiring 6 liters at least were not ever requiring less oxygen. In our experience, they were only going to require more oxygen from that standpoint going forward. So we knew that their lungs were already getting very sick as they increased their oxygen demand. And so that was a good time to get them on the breathing machine because we knew it was inevitable that their lungs would get very sick. And the breathing machine is kind of a double-edged sword. It can sometimes do some damage to your lungs if you go on it, but it also can be a tool that we can adjust settings on to kind of work with the lungs to help them heal over a period of time. So to answer the question simply, at 6 liters of oxygen, we were putting people on the breathing machine. As far as the CPAP and BiPAP are concerned, so for those who are not in the know, CPAP is continuous positive airway pressure, and BiPAP is biannual positive airway pressure. So it's the simplest way to explain it, it's a face mask that is a precursor to the breathing machine. Sometimes you can put it on somebody and help them bridge to not having to go onto the ventilator and get a breathing tube. And other times they go on it and then they have to go on the breathing machine anyway. Those are aerosolizing procedures. And so very early on, we weren't really doing any of that because there was a big thought that aerosolization of any of the respiratory secretions were highly contagious, and still may be the case. So early on, we were not doing any of that. The exception to that is if the patient was in a negative pressure room. This is the advantage of a negative pressure room. It's safe to do aerosolizing procedures in a negative pressure environment because those aerosols are eliminated from the room. So we did have a few patients that more so when it was time for the breathing tube to come out, we would put them on CPAP or BiPAP or high flow nasal cannula oxygen just to help them bridge and get them back to kind of some sort of normalcy when the breathing tube is ready to come out after many of these patients spent 7 to 10 days on the ventilator.
Nicole, is that pretty typical of the way that you were approaching things in New York City?
So a little different. So we were much more lenient about what we did. We had a lot of people on CPAP, BiPAP. We kind of amped it up. So somebody was coming in, they maxed out nasal cannula. Then we were pretty lucky. We have respiratory with us. So they're down with our resuscitations and with our patients with us and help us make these decisions. So then if they're not tolerating the nasal cannula, then we can jump to CPAP or BiPAP and then see how they do. We were doing this in like curtain rooms, not necessarily, it was everywhere, these type of patients. So it didn't matter where we were doing it to whoever was okay with it and if they were tolerating it, but it's pretty uncomfortable. It's a massive mask on your face and it straps around, and it pushes a lot of, it's a lot of pressure. So it's not the most comfortable thing. A lot of people try to rip the mask off. So if they're not tolerating it and then they're desatting because they're just ripping the mask off, then sometimes we would try the high flow nasal cannula, which is much more comfortable, but it's kind of more taxing. And it's not that great either. And if just clinical picture, if they weren't doing well in either of that and they were already starting to fatigue out and their sats still weren't getting to where they needed to be on max oxygen with the other, like CPAP, BiPAP, high flow, then it was time to intubate. We tried to do all intubations in at least closed rooms, like not a curtain room, just because it can go wrong. You need all your supplies. You want to make sure that you have the personnel, the medications, the equipment that you need. For God forbid something else, it was failed, something happened. But once that was in process, respiratory was with us, they were helping us. And then we usually had the admitting team down there with us too, who was able to then take the patient. Pretty much the whole floors were full. So at most points in the ED, we had boarders team. So we had a geographic admitting team in our emergency department who was just there full time. We took care of our boarders. So it put off some of the pressure that was just on the admitting side of everything and the ED side too. So they were a great help. They were then the ones that were able to manage them in the ED and then get them up to the ICU, which was a great help. And we had palliative care there with us too, who was helping us make those hard decisions. The 80-year-olds, the 90-year-olds who were full code, and if they went on the tube, not sure how well they would do. We got an email the other day, a couple days ago, that our intubated patients, they had a 78% mortality rate. So just because you go on something like this that is supposed to help you doesn't mean it necessarily will. And it really affects your quality of life. And these people are alone. And once they're have a tube down their throat, they obviously can't speak to family via phone or Zoom or whatever video chat they're trying to do. So it's a big decision. And it was helpful that there's lots of people involved and teams that were there to support us with all those people.
Well, thank you for leading me into take home point number 2. I really have been a big proponent of this for a long time, probably because of personal experience and probably because of some of the experiences that I've had as an emergency services provider in the field. Please talk to your family members while they're well and discuss what your wishes would be should you become ill. And please find out what they would want, because you don't know when you could be in that position to make those kinds of decisions for your family member. So please, even though they're difficult discussions, they're really important discussions to have. And I find that people dread those discussions, but afterwards, oftentimes they'll thank me and say, geez, you know what? I feel a lot better even just talking about it. Even though it was a little scary to think about, I feel relieved because I did make my wishes known. So please ask your family members and anybody that you might be able to speak for in a crisis. Please find out what their wishes would be.
And it's important to do it beforehand when you're face to face with your loved one, and it's not something you don't know. Calling from an emergency department when it's already to the point where you don't have time to think about it and you have to make a quick decision, that is super, super important.
Very much so.
Thank you. We have another question. Have you been seeing a number of patients who have abnormal clotting?
I've seen a few cases. I mean, what's interesting is that when we first started having, COVID patients trickle in Rochester, when someone comes in and they're short of breath and, their heart rate's elevated and their oxygen's low, and sometimes they have chest pain and they overall don't look well, as, a medical provider, my mind goes to, are they having a blood clot in their lung? And, if sometimes we just move straight to a CT scan with IV contrast, but other times we run a test. It's a screening test. It's non-specific to lung blood clots, but it can, determine if there's clotting in the body. It's called a D-dimer. So I was ordering a lot of those just per what I usually did. And, we didn't have COVID testing at the time, but usually, D-dimers, I'm used to coming back in patients that did have, these blood clots in their lungs or pulmonary emboli. Would be in like the thousands and 2000s. And then all of a sudden, all my patients I was caring for had these D-dimer levels in like the 3000s. And I'm like, I've never even seen one that high. And then you're CT scanning them, and then they have these like terrible ground glass opacities, and they're like, no pulmonary emboli. But who knows where else the clotting may have been. Now with cases I'm reading now, they're saying in autopsies that they're finding clots in the kidneys and the brain and in the coronary arteries. So, I mean, I haven't seen a lot of it, but we also don't have a lot, per se, COVID in Rochester compared to other places, such as New York City or other hotspots around the world like Italy. We'll say that we've seen strange neurologic presentations in younger individuals who are having strokes. They're having strokes where they have facial droops, slurred speech, difficulty swallowing. Sometimes people are like, I just can't walk in a straight line. I feel drunk. We do a CAT scan of their head and they have a stroke and they're young. I mean, not, usually our stroke patients, 60s, 70s, 80s that we're used to seeing. We're seeing younger people, and then we COVID test them because they're getting admitted and it's positive. So, I mean, there's case reports out there that I've seen, but it's hard to tell as we're not a huge hotspot. So the, number of patients is limited.
I think the message, there's a lot of emerging data that COVID equals clot. And that's my simple message to a lot of our staff. Early on, we didn't know this, and we've learned it over the last 8 weeks. And from my end, on an inpatient ICU kind of side, we actually are putting patients prophylactically on systemic anticoagulation. So the risk is so high that the risk has become so high for stroke and PE, arterial thrombotic events, that we are prophylactically putting patients on blood thinners. And this is a huge area of emerging data. But it's definitely also true for patients who were not necessarily symptomatic with COVID, but would have had laboratory evidence of COVID. And that's where all the emerging data is. It's in stroke. So people who are home who have no symptoms but had COVID, there is that populace exists, and those folks are having inflammatory events, so stroke or a clot in the lung, from their hyperinflammatory response secondary to COVID. So definitely COVID equals clot is kind of the message.
Yeah, it's gotten pretty reflexive to anticoagulate any COVID person being admitted to the hospital. It's crazy. And we weren't doing that in the beginning. And other things with like antibiotics, it was reflexive then. Now we're not doing that anymore, which is pretty interesting how within just a month, weeks, things, major things are changing so quickly.
I see another question in there about how are you preparing for the new COVID-related illness affecting children? I can say I have not seen a clinical presentation of this yet, but I think I probably can speak for all of us. We are reading, studying, learning every day because this stuff is changing so rapidly. As you may or may not be aware, there is a new kind of subset of COVID patients that are presenting in children with this sort of unexplained response to the COVID illness, where they are having some skin issues and respiratory issues and GI stuff and stuff all kind of pulled together. So initially the thought was that perhaps COVID wouldn't affect children as much as it would adults. And now we're kind of seeing some cases showing that it is affecting children. So have you folks seen any of those pediatric patients yet?
Not personally. We've had a few. I don't know exactly what happened. The youngest person I've seen with COVID is 18, but I know it's starting. This is the new wave of it. So next thing.
So
I
I
haven't
think that's
seen
the
it.
answer is reading and studying and trying to keep up with current information every single day.
Mhm.
I keep thinking about every child I've seen in the past 2 months, but I don't think we see so few children where I work that I think I would remember if I saw some. We'd usually send them to RGH or Strong if that was happening. I haven't had to transfer any children, during this pandemic. So, but I've read about it multiple times over the past few days. You want to be prepared in case you are faced with that.
Yes. I see another question. Is the CDC website the best place to get info and research from? I don't know. That's a tough question.
I have a comment on that, and that is this is an ever-changing dynamic situation with lots of conflicting information coming from multiple sources. And I think it's very what's going on in New York and Seattle is not apples to apples with what's happening in Rochester, New York. So it's very hard. Even in our environment, when this started, things were changing by the hour. You were getting an email and being on a Zoom meeting and, then getting a phone call all in the same day that something had changed and was radically different. Even this week, we still have things that are changing. It's hard to say that one source of information for a highly dynamic situation is going to be the best source. I will say that the CDC website is pretty fantastic when it comes to things talking about testing, when it comes to things talking about etiology of disease, social distancing, prevention, hotspots of the country. The Johns Hopkins map is linked there. So it is pretty good. But I'm afraid that, from a community standpoint, your local communities also, you need a good source to get some information from there. And I know locally our county has been very good about providing resources all in one place on our county website. So generally, yes, but it's kind of a loaded question.
I think that's a good point. It's sort of the CDC is responsible for the entire country. So they have to make broad recommendations that fit all of the needs of all of the populace across the country. And Eric's point is a really good one. Different local communities may have different needs depending on what is going on in terms of how many cases they're seeing, how many patients are admitted. So you alluded to one of the other really good websites is Johns Hopkins. It has these maps that you can look at, and you can narrow down basically by state and by individual county on that map. There's a link to the Monroe County website on the Monroe County Health Department website that links to that specific map that gives you information about how many cases there are out there, how many people are on quarantine, how many people are hospitalized. So I think that's a great resource to educate yourself and pay attention to what's going on in your own local health department.
I think it's important to understand that just because it's said once doesn't mean it's set in stone and will be like law. Things are changing, and you have to source check, and you have to make sure that things you are reading are reliable. And just because it's on Facebook and it's a meme doesn't mean it's real.
Great point. There's another question in about, oh, I knew we were going to get questions about medications. So there's a question about remdesivir. I was waiting to hear about hydroxychloroquine. So I suspect I can't really speak to it from an outpatient standpoint. So I'll defer to any of you folks that want to speak about that.
So we are, where I work, we're studying remdesivir. So we have a trial ongoing. It's a blinded trial. So we have remdesivir, hydroxychloroquine, and placebo. So we have patients that are enrolled in those trials, admitted to the ICU, intubated, and critically ill. And we, so short answer to your question, yes, we are using it. The providers are blinded to what the patient is on. And so all that I know as the provider is whether or not they are enrolled in a placebo study. So the patient could either be getting placebo medication, they could be getting remdesivir, or they could be getting hydroxychloroquine. But yes, those are ongoing. Those trials are ongoing. It's a large multi-center trial throughout the United States. And, you know, it's honestly hard to say whether or not it's making a difference from my standpoint. It's just challenging. They're so critically ill that the average ICU patient has 200 things change per day from a clinician standpoint. So there's 200 decision points. So the potential for confounding variables is extraordinarily high. So to say that one thing made them better versus the one of the other 199 changes that were made is exceedingly challenging.
That's a really nice way to put it. I see another question from John. Have any of your colleagues contracted the virus? Have any of you worked with folks that have been down sick with COVID?
Yes, a lot. We were short-staffed for a while of it. We've lost some people in the ED. We just recently lost a nurse 2 days ago. And besides the virus, we've had a couple suicides with all of the stress going on. So it's not just COVID that is the main topic right now. It's making sure that your loved ones, your colleagues, people you really care about are doing okay, because this is such an isolating time. And nobody's gone through this before, so nobody knows how anybody's going to react. It's just making sure that you're touching base with everybody, because you don't know.
I had one coworker that tested positive in March, but they had traveled, I believe, and were in an airport before this all kind of came to Rochester. But they're back at work now. Fortunately, they came out of it unscathed and they're working. And when they were actually out, they sewed us all scrub caps with buttons on the side and headbands. So that was really nice. But we're fortunate in that sense that it was only one person.
Yeah, go ahead, Eric.
We've had some staff get it. It's been very interesting to see the kind of the severity of illness. I can think of a nurse that works with me in the cardiac ICU and also works for me at CHS. And it was the day that the chat bot came out. So we have this thing on our phone that we have to fill out every day. That's essentially a survey about whether or not you're healthy enough to come to work. And he said, you know, Eric, I had a tickle in my throat. And one of the questions on the survey was any sore throat, anything bothering you. And he's like, I don't know why I clicked yes, but I clicked yes. And he ended up getting swabbed for COVID and tested positive. But he said he went home and he had no fever, he had no chills, he had no cough, he did not feel ill at all. And he said the tickle in his throat went away, he felt better, and he's back to work. And then I have two other colleagues who work with me in the ICU, both PAs, that got very sick, cough, fever, chills, myalgias, just feeling like they couldn't get out of bed. And both of them tested negative. They were, walks like a duck, talks like a duck, probably had COVID, but their tests were negative. And so it's been kind of very interesting to me to see the dynamic on that. And the other thing is there are many things unique to this thing, but one of the things that's most unique to me is that the amount of virus that you're exposed to is not correlating with how ill you become. So you can be exposed to very little virus and get critically ill, or you could be exposed to a boatload of virus and be fine, like Jill. So it's very, it's a weird kind of dichotomy. And so that's just been very interesting from a provider standpoint.
I'm glad you talked about testing because we see so much confusion and so much information in the media about testing. Who wants to talk about a nasopharyngeal swab and how pleasant it is to do it and how pleasant it is to have it done when it's done correctly and how that fuels the potential false negative tests? Because there's a lot of talk in the community like, how come there's so many false negative tests?
Yeah, it's
If
like
the
having a
patient doesn't cry and grab your arm, it's not a good test.
If you don't have
That's
lying
mean.
down or their head to the back of the bed, they're going to pull away, and that's not going to be an accurate test.
Like, I want them to complain that I know it's good. Like, if you're like, oh, that wasn't so bad, I swab the other nostril. And I
So
know
for
that
those
sounds
that don't know, it's a big long Q-tip that goes up your nostril with the goal of obtaining material from the nasopharynx, so all the way up your nose into the essentially the back of your throat. It's a very uncomfortable test. It's a test we've been doing for a long time for a lot of other things. I know I did it a lot of times when we had a pertussis outbreak in the community. So it's not a new type of swab. We're familiar with how to do the test, but it's so uncomfortable that it is very difficult to get an appropriate sample. And the timing of the testing figures into whether it's going to turn out positive or negative. So there's a lot of variables and a lot of factors that figure in.
And I think that plays into how many false negatives we're getting. Where you're having these people who, like, you look at them and you know they're COVID, but their swabs are coming back. So we re-swab and we re-swab, and then finally by like the third swab, they're positive. But I mean, you've known it all along. It's just getting it all the way back there, which is pretty hard.
And
I
who wants
think,
to take on the hand hygiene question? We talked a little bit about it before in terms of hand hygiene and mask application and mask, de-application. We as healthcare providers have had a lot of training on how to properly put on and take off our personal protective equipment. But I feel like the lay public has probably not gotten enough information about how to do that. I laugh. I had to pick something up at the store yesterday, my one time a week out trip to the grocery store. But I laugh because I see people in the stores who are not wearing their masks properly. And I have to kind of check myself and say, you can't get frustrated because they just don't know. They haven't been educated. So who wants to take that one for me?
The things you see on the subway that people think are protecting them are quite comical. Where people are wearing like neon orange ski masks where it's like the hole is cut out in the mouth and the eyes, and then there's a nose hole. They're wearing that, or they're wearing the gloves and they're touching the poles. They're touching everything on the subway, which is disgusting. Touching their phone and then scratching their face. And it's just, people just don't understand. So like you were saying, you can't get mad at them because they just don't have the education. But it's just, you sit and you watch and you people watch, and it's just pretty crazy.
I think what's important for folks to remember is that the mask is both designed to protect you as well as other folks. And the reason is the mask is a barrier from you touching your face. We're pretty sure that this illness is not an airborne illness. We think it comes from droplet transmission, which means there has to be some sort of secretion in order for you. So a secretion has to land somewhere. You have to touch it and then transmit it to your face, to your eyes, nose, ears, or mouth. And so the mask serves as a barrier to those secretions going out. And oh, by the way, the 6 feet of separation comes from, that's the maximum distance that a sneeze can travel, a droplet. So 6 feet, that keeps those sneezes and those coughs from sending stuff out, and then also prevents you from touching something and then touching your face. The mask is a barrier from you touching your face.
So wash your hands, put your mask on, try not to touch your face.
Exactly.
Wash your hands before you take your mask off, put your mask in a safe place, And wash your hands once again.
And stay home.
And the mask goes over the nose
Nose
It
and
goes
mouth,
over-
right?
and mouth. And if you wear gloves and then you touch everything and then touch your phone and then take your gloves and your mask off and then are all on your phone. I mean, when I grocery shop or go to work, my phone is covered in saran wrap. Also, when I take care of patients, I just tell them to throw their gloves away before they come in patient care area, because I say you're just going to get everything that we work so hard to clean here dirty with whatever you touch with those gloves. I'm like, whatever you do out of here, fine. But I try to educate them and say, everything you touch. I mean, you'd be better off just carrying around a little hand sanitizer and just sanitizing your hands if that's available to you.
Excellent.
Well, thank you all so much. This has been very informative, and you can see from some of the comments that people not only appreciated the information, but certainly we appreciate the work that you all are doing, the hard work, the mentally tasking work that you are working on. It's so important and so vital, and we just cannot thank you enough. We are at the end of our presentation. If anyone does have additional questions, you can email them to ritalum@rit.edu, and we will direct them to our presenters. And again, all of our audience members will receive an email from us in about a week to 2 weeks with a link to today's webinar recording. Thank you to our RIT alumni at the front lines for joining us today, and again, for your important work. For everyone, please visit rit.edu/alumni/tigers-staying-home for a listing of our upcoming virtual events. We have several webinars in the coming weeks, and we would like to include you in as many as possible. Please exit the webinar simply by closing your browser window, and please do let us know what you thought of this information through a brief survey that you will receive via email. Thank you all. Have a wonderful weekend, and please stay healthy.
Thank you.
Thank you, everyone.
Thank you.